Okay, so here we are for round two. I see most people have come back, that's good. What I'd like to do for this, and this is sort of the focus of the AUA's best of programs, and I do think this is a really wonderful effort on the part of the AUA in collaboration internationally with multiple urological organizations around the world. And I do think that in today's world, creating these connections and bonds of education and clinical care and friendship are extremely valuable. And I hope we can continue to do it. And I am very pleased that the AUA has invested in this, and that all of the sharing and collaborating organizations have also decided to invest in this. So I don't know who of you made it to the Boston meeting. For me, it was great fun because it went back to where I had worked and lived for 20 years, and got to see my daughter. They've gotten to the age where now I have to get on their schedule rather than on mine. This is going to be really a run-through of what I thought were some of the highlights of pediatric urological presentations. There is no specific theme to this. We'll just sort of move through fairly quickly. And some of these are projects that are just emerging and are really a glimpse at what the future may hold, and others are ongoing studies that you may be familiar with. And they range from very practical things such as this. This is a comparison from Indiana of caudal versus dorsal penile nerve blocks for penile procedures. This is certainly something that we often argue. My anesthesiologists like doing caudals. I like doing dorsal penile blocks. I think they're roughly equal. And then a similar paper from Oregon looking at the use, actually a slightly different type of block with ultrasound-guided pudendal block in children undergoing hypospadias repairs. And this is actually an interesting block that one of my anesthesiologists does use in a modified fashion. And this is really getting the pudendal nerve down near the where it comes out of the ischial foramen, and doing the block, and then in contrast to a dorsal block. The conclusions were that pain relief from caudal block was superior to penile block. Other studies have shown equivalence. My sense from this is that the caudal is more reliable, and that if you have someone who is experienced doing a penile block, you will probably get equal benefit. But the caudal block tends to cost more because anesthesia bills for it. We don't actually bill for it. And it can take more time, although I have had anesthesiologists who are exceptionally fast with caudal blocks. The ultrasound-guided pudendal block certainly is going to take more time. It has the benefit over a caudal block that there's no retention and there's no ambulation limitation. They said there was no increase in preoperative time. I'm not sure I totally believe that. I can't imagine that that's that quick, at least in most of the anesthesiologists I've worked with. So I think caudal blocks are certainly as good, if not a bit better than penile blocks, and we do tend to encourage them. This is an area of interest, and we actually have a urodynamics course that we're giving in a few weeks in Dallas, and hopefully we will continue to do this and open it up more widely to pediatric urologists. And this was a look at how much interrelator reliability there was in interpretation of urodynamic tracings. And this was based on an initial study from Vanderbilt, and then they did multiple studies here, and found that there was a great deal of disagreement in certain areas, particularly EMG, synergy, detrusor overactivity, and bladder neck and compliance, at a point of less than 50% agreement. So there's a lot of difference in how we interpret urodynamics. And this is an area I think crying for better research and standardization within our field, because if you think about looking at any study that bases its intervention, for instance, on urodynamic findings, such as DSD or noncompliance, if you're going to do an augment or a bladder neck repair, that if you can't agree on what the baseline is, you don't know what the patients are. And so I think this is a very important area that needs to be studied and made more rigorous over time. So there's a high variability in interpretation across institutions, and as I was saying, a standardization of interpretation to enhance quality of collaborative research, I think, is critically important. And that's not going to be easy to do because pediatric urodynamics is still not totally simple. Going back to hypospadias, this was a report from McMaster's Children's in Canada, and that the biggest predictor of post-operative complications after a TIP was the glans groove, not preoperative testosterone stimulation. There's been a lot of controversy that using testosterone prior to hypospadia surgery may induce more complications. It never quite made sense, although people were trying to create explanations. My sense had always been that you were using testosterone in the smaller penises, trying to get it a little bit better, and they were going to have a higher rate of complications. And this is largely what Braga has shown, and that they were looking at reoperation rates in severe hypospadias, that still high reoperation rates, 30 to 80%. Cosmetic outcomes are improved, but the glandular groove and the depth of that is really the surrogate for urethral plate quality and was an independent risk factor for complications. And I think that makes sense. Warren Snodgrass has talked a lot about the size of the glands and the 13 millimeter cutoff. Below 13 millimeters, much higher risk of complication. I think that's probably goes hand in hand with the glandular groove characteristic. And I'm sure most of you realize that if you've got a deep glandular groove, that's a better urethral plate. They're probably going to do better. One of my questions still is, well, what do we do differently about this? And do you then try not to get a meatus actually at the tip, or just and simply accept a coronal opening for some of these severe kids? And that's still an unknown. Journal of Urology did a number of sort of highlights as well, and this is actually a paper from my current institution, but came out before I was there, and looking at a validation of the TWIST score, which is a clinical diagnostic tool for determining whether there's likely testicular torsion, and this is guided by Linda Baker, my current colleague, and the benefit of this is that the non-urologist can make a clinical assessment of the child and say this is high risk or not. From this, what they found is that you could, by calculating this TWIST score, which is shown here, then you can categorize into low risk and high risk and an intermediate risk. Low risk, you don't need an ultrasound. High risk, you just move straight to exploration, which could reduce, in essence, the time spent doing scrotal ultrasounds. The other benefit that we've achieved from this is we have a policy. If we get a call from an outside physician with a child in the emergency room at their hospital, and they feel that the kid qualifies for a high risk, we just send them right to our operating room. We don't go through our emergency room. We save over an hour, and it's become a really very nice clinical tool for getting these kids moved through the system. But I would advocate and encourage you to look at this and consider using this, pass this to your colleagues in the emergency room. This is a good clinical tool for predicting the likelihood of torsion. You probably know just as well as I do that if you can talk to the kid and do a quick exam, you know if it's torsion or not in the vast majority of cases. There's no reason to do an ultrasound. Just get them to the operating room and don't waste time. This was a study that, in essence, is, I suspect, putting one of the last nails into the coffin of the Zhao procedure, which some of you may be familiar with. This was a procedure that emerged out of China and then was also studied in Detroit. In kids with myelomeningocele and lipomeningocele, where they would transpose the sensory nerves, and you would use a sensory feedback arc from stroking the thigh to trigger bladder contraction. It seemed to work in some patients. A lot of them were spinal cord injuries, not spinal cord developmental abnormalities. People claimed it would work in kids with spina bifida, and this was a randomized study looking at the GU effects of the Zhao procedure, which, whenever it was presented, it always seemed a little bit too good to be true, and I suspect that's the case. And so this is, the Zhao procedure had claimed to create a reliable scratch-initiated bladder contraction and controlled voiding. This was a randomized prospective double-blind study, compared cord detethering with the Zhao procedure. No difference was found between the treatments. None had voluntary voiding or continence after the Zhao procedure. So it took a big study. This was funded by NIH. It was hard to get it done, but I think that has been consigned to the history books and probably is not worthwhile for our patient population. This is a commentary by Saul Greenfield and really reflects what I was talking about the interpretations of studies related to reflux. And what Saul was pushing is that you really have to look at methodologies and what your patient selection is, and that's this. It's a commentary, and it looked at studies examining reflux and antibiotic prophylaxis, and looked at 18 particular studies, many of which were incorporated into the AAP guidelines, as I talked about, and within those you see significant subpopulations and methodology variations in these published series. And meta-analysis using these studies may be inappropriate and lead to inaccurate and flawed conclusions. And there are a number of high-level statisticians on this commentary paper. And I think it's important to recognize that, be very cautious about interpreting small studies. It was very interesting in the River study, and I had the opportunity to be the chair of what's called the Data Safety Monitoring Board. So I saw all the data coming in, and we sort of, were the supervisory board of the study. And when we looked at the broken out data from different centers, depending upon which center you had very different results. So if you only looked at one small center's results with that study, all the same criteria, you could see very different results. So be very cautious about over-interpreting a study that has 30 or 50 patients. With reflux and things of that nature, even the River study with 600 patients, 300 in each arm, there was a question as to its significance. So be cautious. This is a good paper to read to get a perspective on how we learn about clinical medicine through big studies. This is a study from Vanderbilt and Pittsburgh looking at sacral neuromodulation in children, and it was a prospective study and looked at 24 girls and 6 boys with BBD refractory to standard therapy, and demonstrated a clear, significant improvement in quality of life and symptom severity. Best results were seen in those with uninhibited bladder contractions and lower BMI. I think that sacral neuromodulation is a new technology coming out, may be very helpful for us in some of these kids. And of course, this may be relevant in some of these children with significant reflux where you can't get their bladder and bowel dysfunction under control and are having infections, and you're looking at surgery. But I think this is something to anticipate seeing more information about. While this is a small study, it is certainly worth paying attention to. This is another study actually out of our group in Dallas, again, before I got there. And this addresses a big controversy that has been circulating. This was long-term outcomes of bladder neck reconstruction without augmentation cystoplasty. For a number of years, Warren Snodgrass was very convinced that you could select patients who did not need augmentation. He really didn't want to do augments. He recognized significant risk of complications, no question about it. But you have to be careful with these patients. And these were kids followed from that original exploration who had bladder neck reconstruction, either slings, sphincters, or bladder neck tightenings, who did not have an augmentation and were then followed. And the problem is that you need to really follow these kids incredibly closely. And we saw a significant incidence of augmentation being needed due to kidney changes, persistent incontinence, new reflux. They had to have follow-up continence procedures. They had greater than 50% anticipated upper tract changes, and even chronic kidney disease in upwards of 20%, using, in essence, these are reverse Kaplan-Meier type curves called estimated 10-year incidence based on early data, and these were followed for a number of years. We've been augmenting a lot of these kids lately, and I've seen a handful of them, and I really think that, yes, we all know the complications of augmentation cystoplasty, but some kids need it, and we just have to manage the complications, because your alternative is either persisting incontinence, a diversion, but we should never sacrifice the kidneys for the sake of continence. And I think we need to be very cautious. This has been controversial. Warren Snodgrass, as those of you who know him, can be a very strongly outspoken advocate for his beliefs. But I think in this area, we need to monitor these kids carefully and strongly consider doing augmentation at the same time as a bladder neck in those who do not have good compliance. And I think we're trying to figure out how to select these patients better. This was a study out of Indiana that quantity, not frequency, predicts bother with urinary incontinence and its impact on quality of life in adults with spina bifida. And this was a survey type study where they were looking at quality of life in a large number of adults with spina bifida. And quantity of incontinence was the best predictor of quality of life and bother, not the dry interval, not the number of pads. So it's something to sort of keep in mind as you're making decisions in the childhood population, that it's the quantity of wetness, not the interval or the ability or need for pads that seems to bother them as they get older. And obviously we don't want them to have any incontinence, but that's not always achievable in real life. This is a look at the CDC's study on prevention of urologic and renal issues in children with newborns and young children with spina bifida. This is CDC has a study on spina bifida. Earl Chang, listed here, is one of the lead coordinators of that. And this is developing a urological and renal protocols for these children. And not that we're going to go through all this, but this is now out that is trying to standardize our approach to kids with spina bifida from a nephrourological standpoint, and focusing on infections, renal function, scarring, and then trying to institute clinical process improvements. I mean, this is a lifelong problem, obviously. We are heavily involved in it early on, and having these sorts of national-based protocols makes good sense. There was a very nice presentation from this International Bladder Extrophy Consortium that Asim Shukla at CHOP has been working on, and going over to India and working with the teams there to develop their abilities to manage these complex patients perioperatively and going forward. And it's both a patient care and an educational program, and I think it's been quite nice to see it grow. This study from Cleveland Clinic looks at what happens to kids with myelomeningocele, where, why, and how they've been getting health care. And what they're identifying is that insurance, oddly enough, is not the primary obstacle, which I would have thought it would have been. But it really relates to patient factors in that they didn't know what to do, so education, and didn't want to come, which is orientation. It's something that we can address. We can hopefully change those things. And it reflects providers as well who don't feel comfortable and don't have the background in terms of caring for these patients and in providing follow-through. The theme of urological outcomes in spina bifida was a significant one at the SPU this year, and this is a paper from University of Alabama in terms of looking at transition of care. And this is a thing we're focusing on a great deal at a lot of institutions, still trying to sort out how do we make sure that the kids we've taken care of through childhood are not going to fall off a cliff when they become adults and are being cared for by adult urologists who are well-meaning but may not have the resources. Kids, they really looked at those children who had an effective transition program versus those who didn't, and you can see that there are actual some clinical variables that are enhanced. And then if you look at urological complications in adulthood, there does sometimes seem to be a benefit, although not huge, but I suspect that over time these will magnify going forward. So without a doubt, it's going to be better for these kids to be run through a transitional program. And you can see this in terms of the types of bladder procedures needed, suggesting that perhaps with a transition program, there's better management and fewer or lesser need for these complicated procedures. This was I think we're winding down here, urologic complications in pediatric transplant. The big issue was kids who had symptomatic reflux, strictures, or graft failure. Looking at the presence or absence of bladder pathology was the key predictor. And I think we know this, but again, it needs to be emphasized that those kids need to be prepared before the transplant rather than after. And unfortunately, if the transplant surgeon does the reimplant, they also had more complications in the bad bladder, and this was something we noticed long ago in Boston as well. And those are the patients that we need to be working with. And then finally, just a real quick commentary. Mike Ritchie gave a wonderful talk on looking at the possible use of partial nephrectomy for Wilms tumor. And although we would all like to do this, his outline and his thinking on this, I think, is very good in that the risk of ESRD remains low in these non-syndromic kids. There's limited data to support doing this in terms of stages of chronic kidney disease. They need better studies. And strong consideration for nephron-sparing surgery in patients at risk certainly would be there. But you have to draw a careful balance. And I think at this point in time, we do not have justification for doing routine nephron-sparing surgery for Wilms yet. But his final point is that we have to continue to be involved as a cooperative group. So I know that was fast, but there was a lot of good material. And we hope that as many of you can attend the San Francisco AUA next year as possible. Thanks very much.
Thank you very much, Dr. Peters. So we had some changes. So the next lecture will be on pediatric nephrolithiasis, current techniques and strategy. And then, if time allows, we will go through pediatric case discussions. The lunch will be served at around 12 p.m. or 12:30, and it will be in the social club outside this building near the swimming pool. So you need to go to the end of the corridor and then turn left and then go down to first floor, go out of the building and then turn right and it will be on your left side. So just if you go outside the building, you turn right, then you see the social club on your left side, the swimming pool.
Follow up with some.
نحط هذا ال AUA work. Okay, please.
Okay. So as our final discussion, we added on nephrolithiasis, and this has been a long interest of mine. I went into urology because of kidney stones. We were doing open stone surgery then. It was the most satisfying surgery I could imagine. And then they came up with the ESWL and ureteroscopy, and so I don't do much open stone surgery, but still do a lot of endourology for this. And in Texas, we see a lot of stones due to the weather, and I'm sure you all see even probably greater numbers. So kids and stones is just not simply smaller stones. It's a very different field in some ways. In other areas, there's overlap. I'm going to very briefly touch on how we initially evaluate these kids, some of the key metabolic causes that you don't want to forget, basic strategies for curative therapy, and for medical management. In terms of initial evaluation, we are really emphasizing the focus on avoiding invasive evaluation as much as possible, either through instrumentation and certainly for radiation exposure and particularly CT scans. And I really believe that ultrasound should become the default initial imaging test when stone is suspected. Now, if you need to characterize a complex stone for a procedure, yes, you need CT. But if we can avoid using it on a knee-jerk basis in every single kid who presents with flank pain and some hematuria, that would be good. There are a number of studies that have demonstrated that the more CTs you're exposed to over time throughout your life, the higher the likelihood of increased risk of malignancy. We have also seen a number of reports that have effectively shown that ultrasound's equally effective in determining stone location, burden, and therapeutic needs. It doesn't always identify the stone, but if you have a good clinical scenario and you factor in what you need to know to take care of that patient at that time, it can be useful in nearly all situations. Cystoscopy in children requires a general anesthesia, so it's used very uncommonly until therapy is needed. The idea of simply putting up a stent temporarily is something we don't do very often unless we know we're going to need to proceed with therapeutic intervention. And these are some old studies. This is a recent study of a kid who presented with 2 weeks of abdominal pain, hematuria. You can see the hydronephrosis. It's not very severe, but it's clearly present. There's no debris. You can see the stone in the distal ureter. She was afebrile. Her urine was clear. We started her on hydration, pain management, and medical expulsive therapy, and she passed her stone. This told us what we needed to know. We did not need to do a CT scan. So your goals of initial evaluation then are similar to the adult. You want to confirm the diagnosis. You want to assess the risks of acute complications, obviously infection and obstruction, define your stone burden, and identify any associated anatomic factors that are going to contribute to your therapeutic decision making. And you want to initiate an appropriate metabolic evaluation. And whether you're, and this is an old-fashioned IVP that shows a unique anatomic situation with a big Kale seal diverticulum with a stone, we would have done that with an ultrasound or potentially a CT today, but we need to understand these factors. Our basic metabolic evaluation is going to include serum studies shown here, electrolytes, calcium, phosphorus, magnesium, and parathormone if your calcium is elevated. And then we typically will initiate a 24-hour urine study. I like to wait until after the acute episode, but this is going to look at volume, pH, calcium, sodium, citrate, uric acid, creatinine, oxalate, and cysteine. And if only as a baseline, it rarely identifies something that you're going to immediately treat. But this has a lot of value over time in managing these patients to know from where you started. Now, in kids, conventional wisdom has suggested that most children have an identifiable metabolic cause for their stones. I'm not sure that I totally believe that, because we see hypercalciuria, but we're not sure what it means, and we don't know whether it truly predicts anything clinically relevant. A lot of large reviews have also included up to 50% with infection-related stones. That's largely historical data that's generally irrelevant today. Some parts of the world, that's probably still true. And nowadays, it's much fewer. And those are kids with obvious patients such as neurogenic bladder or reconstructions. Now, depending upon your definitions of normal, the underlying etiology of most stones in children today cannot be identified in such a way as to impact therapy. And yes, you can identify nominal hypercalciuria, but does it really change your therapy in a way that is going to affect clinical outcomes? And I don't think it does. Our appropriate evaluation is therefore undefined. I still feel we should do it, partly from a research standpoint. There are, however, several metabolic conditions that form stones that should not be missed in practice, and that's the importance of our metabolic evaluation, because early identification and specific treatment can clearly reduce the burden in these kids. So what I like to talk about in these rare stone diseases is, are we talking a zebra? And in our jargon in medicine is if you hear hoofbeats, don't think it's a zebra, it's probably a horse. Unless, of course, you live where zebras live, and we don't. So anything called a zebra is some unusual but possible condition that is rare. They do occur in these stones, and we need to at least be tuned to it. The warning signs to me is the first stone is in a pre-adolescent. Stone presents with either acute kidney injury or chronic kidney disease. A child who presents with reddish-brown diaper stains as an older child, not the newborn with uric acid stains. And this can be one of the APRT-related stones. These are the purine metabolism stones. Child who presents with stone and growth retardation, has a family history of nephrocalcinosis, and especially a child with there may be a history of primary hyperoxaluria, and they may present also with bilateral stones, or a radiolucent stone that's not uric acid and is therefore potentially xanthine. This is just a list of some of the rarer stone diseases that we don't want to miss. Again, you're not going to track down everyone and do the full workup, but you want to at least be thinking about it. Cystinuria is the most common one, and that clearly, it makes a huge difference if you can start intervening early and prevent further stone burden. The others are less common, but we need to know about them. The one I really don't want people to miss is primary hyperoxaluria. Is again, if you can start them on medical treatment, I think you can have a better long-term course. And we won't go through all these in great detail. These are the 5 that you want to at least be aware of. PH1, again, presents relatively early, often bilateral disease. This is a metabolic disease with an identified genetic cause, 3 subtypes now. Unfortunately, it's only curable with liver-kidney transplant. Medical treatment can ameliorate it a little bit and reduce the burden. Cystinuria, I don't need to go through all the details, and you're familiar with that. Medical therapy is reasonably effective, has a lot of side effects, and is expensive, but the options are not otherwise very good. These stones are difficult to take care of. Renal tubular acidosis, key thing is recognize it, look for the clinical pattern, and then manage appropriately and work with your nephrologist on that. Keep in mind the newborn in the NICU who's been on diuretics may have nephrocalcinosis. Almost always those will go away if you pull the diuretic off, and it's usually furosemide. And then finally, Leishmanian is in that context. These kids who develop uric acid stones, they're radiolucent, but also have self-mutilation and developmental retardation. The problem with them is you put them on allopurinol as treatment. If you treat them a little too aggressively, then you will ultimately get xanthine stones, and which I've seen in a few of these kids. So important to recognize these. We're not going to go into great detail. If people are interested, I do have a talk on the rare stone disease. I gave it a couple years ago at the fall meeting. I'd be happy to send it to anyone if they're interested. It's sort of tedious stuff. It's all the metabolism things, but useful to be aware of. Ultimately, we are called upon to manage these patients with curative therapy. The techniques that we use are essentially identical to an adult, but size differences create significant challenges, and we don't have perfect tools in kids. The strategy I've always employed emphasizes a single intervention to limit anesthetic episodes, and that, of course, can also impact your drainage strategies. And a lot of adult stone therapies involve use of temporary ureteral stenting that requires cystoscopic removal. In the kids, that's a second general anesthetic. So I use extraction strings very frequently, if not always, in any ureteroscopy work I do. And they work great. I use them in my robotic surgery as well. I've not had much trouble in terms of kids pulling them out early. So the approach of at least trying and aiming for definitive stone removal with a minimum of interventions is, I think, a key goal in pediatric stone management. Not always possible, but we try. And this is just how I tape one of the little extraction strings. Foley catheter still in this child, but this has worked very well, and depending upon your preferences for ureteroscopy as to how long you leave a stent in. I do tend to leave stents in almost all situations, although some people have reported you can get away without a stent in some cases. You also need to factor in your associated congenital anomalies. This is a child with multiple calyceal raspberry stones associated with a significant UPJ obstruction. So in general, we're going to be repairing or dealing with both. And today, with a robotic pyeloplasty, we would always get the stones out at the same time. And that works quite nicely. Basically, ESWL, percutaneous nephrolithotomy, ureteroscopic stone removal, and open and laparoscopic stone surgery are still our standard options as they are in adults. ESWL, initially when it first came out, we were a little worried it might affect growth of the pediatric kidney. Most of the studies have shown that it doesn't. The older studies were in kids who had multiple comorbidities who had reduced growth, and that may well have been secondary to their other diseases. We've never really defined appropriate energy levels in terms of safety versus efficacy, so it's still largely very much ad hoc, and everybody does it a little bit differently. Does seem to be that stone fragments pass more readily than in adults, and I have seen some big stone fragments pass in kids after SWAL. Can be used effectively in staghorns. You may need to do multiple courses, and that's where you have to start deciding, do I want to do a PERC or an SWAL or do sandwich therapy? And those are judgments that have no simple formulas. Initially, when we started using a portable machine, which was lower power, we thought we had pretty good results, but we actually looked at that and not so. So I'm become less enthusiastic for the smaller portable machines in recent years. The functional issues, just a number of more recent studies that have looked at this. None of them are really recent because I think this issue is pretty well settled. No reduction in GFR, normal renal function and growth, and no effect on growth in a number of these studies. So I think everybody's comfortable that SWAL is safe in kids by and large, but we're drifting away from its use. And part of the problem is that, those of us who were used to this, the HM3, which could break any stone, it's kind of become a dinosaur, unfortunately. And so it's not available. They're not making it anymore. This was the one I used at the University of Virginia, and they were keeping it together with duct tape and spare parts. These are the modern portable systems. They look good. I think in some situations they're great. You can either use ultrasound or fluoroscopic guidance. The shockwave generators under the body. They're portable, relatively inexpensive, and it's a good option to have. Unfortunately, in some kids, and this may have been an earlier generation lithotripter, but when we looked at this in Boston, in 101 patients, we had an overall stone-free rate of only 59%, which is really not very good. Predictors of failure were kids with abnormal GU systems or larger stones greater than a centimeter. So a very limited number of stones that you could treat. I think we do a little bit better now, or we've adjusted the power. We may have been too cautious because this study from Cincinnati did show a better stone-free rate of 68%, moved up to 74% after 2, but still not what we ultimately can get with other modalities. And so nice to try. I think it's reasonable. But the results with the newer generations in kids have just not been great. SWAL and Staghorn, and this is Henri Lotman in Paris, who's a big enthusiast for SWAL, did have reasonable results for Staghorns under 2 years of age. In the high 80%. I think they're probably smaller stones and maybe more fragile. But certainly a reasonable option to consider. In infants, safe and effective, but it's much harder to get these kids positioned. I think you do run greater risks of obstruction and infection. Pre-stenting has been recommended in some. I think actually a stent in the smaller kid may obstruct passage of fragments. So I'd be cautious about that. And most of these I've managed without a stent. And stone-free rates of up to 88% have been reported in this small population. This is a very nice review article by Smaldone and Steve DeSimo in 2009, looking at multiple studies, and this is for SWAL. The lower success rates were clearly seen in lower pole stones, bigger stones, and larger series. So it's nice because they have the number of patients reported, and when you get bigger patient series, I think you have a better reflection of reality and that the success rates are not really as good as you might think. So again, be cautious about small studies. PCNL is well established and safe. I've been doing it in kids since early 90s, and we actually evolved the mini PERC system in kids, and Steve DeSimo took that over and enhanced it very nicely and published it. I think in larger stones, it certainly is reasonable for PCNL, but it may require follow-up shockwave lithotripsy or several steps. I think you can also integrate percutaneous access with antegrade ureteroscopy, which may be better than retrograde in selected cases because you're going down a dilated ureter rather than going through a small ureterovesical junction. Depends upon the situation, but that's not something to rule out, even though it's not standard. This is a partial staghorn that you can see with a pelvic stone and an extension into an infundibulum, and this would be ideal for a PERC. Today we might do this ureteroscopically as well, but I think it would do well with a lower pole PERC access. I typically use ultrasound guidance rather than fluoroscopic. I taught myself with Lou Cavusi how to do these, although I usually bring the ultrasonographer in. At my current institution, we ask them to do it separately, and that works fine. But ultrasound is really a nice technique to get access. You can see it real time, and you can actually identify when your needle's in the right place. This is some of the tools. The mini PERC is something that Steve DeSimo modified from a suggestion that he and I had talked about, using a peel-away access sheath. It gives you either a 9 French or 10 or 13 French sheath that's not rigid but is stiff enough to take a scope and to get into a small kidney, and yet you're not making a big hole because all the other systems were 21 to 24 French or bigger. Then you can make a small puncture. The access sheath goes over a wire, this is a nice way to do low stone burden stones, particularly with laser lithotripsy. Ureteroscopy is well established in kids with needle scopes and laser. I think that's probably standard now worldwide. Usually you don't need ureteral dilation, but occasionally we've had trouble and need to pre-stent, and that may be safer. We've come up with a method for accessing really small ureters using sialic duct dilators. I didn't know they would do endoscopy of the sialic duct to get parotid gland stones, but these are very small dilators that are great in small kids and actually allow you to dilate the distal ureter safely. Unstented procedures are safe. I don't do many that way. I just use the extraction string, so I don't worry about leaving a stent for a few days. These are some of the current either semi-rigid or flexible scopes. We've actually, and just an example of using these, I'm sure you're familiar with it. I think the youngest I've done with a retrograde stenting is under a year, an 11-month-old boy with PH1. And I think the biggest advantage, of course, is you have access to the entire collecting system relatively easily. We've gone to, actually, I don't think I have a picture of it, disposable scopes. Boston Scientific makes one. For our practice, they're actually cheaper because we have the cost of the scope and servicing them has turned out to be so high. The disposable scopes are good, their visualization is good, and we're exploring whether we're going to go completely over to them. This is again from the Smaldone article comparing PCNL, S-wall, and retrograde ureteroscopy in different types of stones, and you can see the various success rates. No marked difference between them by and large, so they're optional. Clearly people are going to ureteroscopy with better instruments, with laser. This seems to be your first option. So open stone surgery and laparoscopy, very unusual indications. Once in a while we need to do it. Certainly would do it if there's an associated anatomic abnormality that we're going to approach, particularly a UPJ or a calyceal diverticulum. I have used it in big stones and difficult stones such as cystine stones, which are very hard to break. They're hard to break no matter what. And Limited experience, but it does work and is an option. This was probably the last open stone case I did with a 5-year-old with a big infundibular pelvic stenosis, a thin cortex. We were worried that we'd shred the renal tissue if we went in with a perc tube to get the stone, so we did this open. It's still a fun operation to do. This is one of the first robotic pyelothotomies, a big cystine stone in a teenager, able to get it out in a very brief operation, sent her home the next day, got her stone free. Unfortunately, she thought that meant she didn't have to take her medicines, so we did a staghorn on the right side the next summer. These cystine stones grow so fast. She takes her medicines now. So finally, in medical management, and very briefly, we ask, how do we select those who need medical therapy? What are your goals? What are your endpoints? And I think it's very important because I'm very hesitant to put a child on medication because you don't know when you're going to finish, and there is no real finish. And it can be a lifelong course. Now, for cystinuria, for PH1, it is going to be a lifelong course, no question. But for the hypercalciurics or hypercitraturics, I really focus on dietary and hydrational strategies first. And the basic principles, hydration, hydration, hydration. You all know this. This is pretty straightforward. Limit dietary factors, particularly salt and oxalate, increase citrate, lemonade, and orange juice. And I really think creating a program that is simple and practical that parents and kids can understand and are going to stick to is the only way for this to work. Otherwise, you're just hoping against hope that this will prevent another stone. We do a 24-hour urine collection. There's still some question about its value. I think it will detect a few patients with severe abnormalities of calcium metabolism or the unusual child with a significant metabolic issue. Certainly, you're going to want to screen for cystinuria in most kids. I think 24-hour urine studies are also helpful to monitor adherence to the management strategy, particularly hydration and salt intake. And I've used that a lot to show to parents, you tell me you're drinking, but here's the numbers. You're not drinking enough. Motivating is a challenge. The candidates for medical therapy are those with recurrent stones or obviously an identified metabolic abnormality that has a specific treatment. This is not simply hypercalciuria. And if we're going to do it on medical therapy, I'm going to typically do it with nephrology in combination, and we have a multidisciplinary stone clinic. This is DeFore's report that he did show that higher rates of calcium excretion and lower citrate did have a predictive value for recurrence. That makes sense. This is one of the few studies that has shown that. We did some work on that as well and couldn't demonstrate it quite so clearly, but I do think it's there. That would still not justify, in my mind, starting a kid on thiazides. I would push to improve their hydration and modify their diet. So basic principles then, we try to minimize invasiveness, both of evaluation and management, minimize the need for multiple treatments and procedures, aim for a definitive single intervention based on what we know about stone location, size, and your intervention technique, rule out the major metabolic abnormalities, initially use hydration and dietary preventive measures, and there's relatively limited need for medical therapy in most kids. So just remember, can't treat children as small adults, and kidney stones are not just smaller stones. Thanks very much. I think we should do some cases, yeah. That's what I would have. I think they're the valuable ones.
Actually, I have a couple of questions.
Yep.
About the CT usage in nephrodialysis, pediatric nephrodialysis. What about the low-dose CTs?
And now I've just learned, literally I gave this talk last week, and there is now a hyper low dose or super low dose CT that apparently has reasonable resolution. I think if that can get you down to the level, and what I heard was at the level of a KUB, then that's great. That'd be perfect. The challenge is getting people to use it, and I don't know whether they do automatically. Because I see so many kids who come in with some abdominal pain and they say, well, let's rule out an appendicitis, rule out a liver thing, and then they see the stone.
No, I mean doing a CT before planning surgery. So
Oh.
Not for initial diagnosis.
Oh, okay, yes. No, I think if you need to know the anatomy, then absolutely. And with these super low dose CTs, we may well be able to get the radiation dose even lower. You need to know anatomy, there's no question. What I don't like is we just see so many kids who come in with abdominal pain who are getting CT scans for anything.
What about the
No, I was trying to point over you, but save the best for last.
So thank you very much. What about the medical explosive therapy? What do you use?
Yeah.
What are the doses in pediatrics?
Yeah, well, we use Flomax, tamsulosin, 0.4 milligrams. There is no evidence, actually most of the evidence says it's not effective. And we just had a conference about it and argued and reviewed this. I'm probably going to give it up because I don't think it really has a benefit, unfortunately. The one thing that's nice is parents sort of think you're doing something rather than just waiting, which is what you're doing.
But even says that it doesn't increase expulsion rate, but it says that it decreases pain and the need for for pain reducers, pain management, and it might make the stone pass faster.
Yeah, well, the data that we looked at, we didn't focus on the pain thing, and if there's evidence that it does that, then it's worth it, because that's certainly better than either nonsteroidal or certainly narcotic medications. Yeah, I mean, I've been using it for the last years, but never with a great deal of conviction. Yeah.
Prepared to treat medical management for renal stone, or refer it to a nephrologist so he will work on the patient. You are the one who treats him, or refer it to a nephrologist?
Yeah, it depends. Sometimes they come through nephrology, they're referred to nephrology first. What we now have a multidisciplinary clinic that is nephrology, urology, and dietary therapy. So and these are their complex recurrent stones or with known metabolic conditions. What I found in my previous practices was that when I either referred them to nephrology or they came to me from nephrology, they were already on medical therapy. And I just was uncomfortable at, what are your indications for starting a child on thiazides? Yes, recurrent calcium stones, and you've tried all the measures, yes, that makes sense. But I was seeing a lot of kids put on thiazides that I'm not sure needed it. But I think a multidisciplinary approach is the best, because we have a different perspective than they.
Thank you, Craig. During the spectrum of management of these kids, what would you recommend doing a functional study, and what would be your preference of choosing, among all the modalities that we have? Is it a DMSA, is it a MAG3, or is it something that you segregate according to the anatomical configuration of the kidneys?
Yeah, I don't use either DMSA or MAG3 very much for stone disease. Now, if there's a concomitant hydronephrosis, then I'll get a MAG3. If it's a a huge staghorn, and you're wondering about the function of the kidney, then a DMSA. But typically, if they have hydronephrosis and a proximal stone, I'm going to assume there's obstruction and judge based on symptoms, size, degree of hydronephrosis. I haven't used a MAG3 to assess the severity of that obstruction, but you certainly could. It would make sense, because you don't want to wait. Because once in a while, and I've seen this post ESWL, where you'll have an acute obstruction without any symptoms and not a lot of hydronephrosis, and they have high-grade obstruction. I mean, that silent obstruction is sort of dangerous.
Well, why I'm asking this, sometimes you come across cases where you do have ectopic kidneys, and in those odd cases, it's sometimes difficult to assess the function, so you're just going to judge whether you're going to do an intervention, whether you're going to leave it, or you're going to do, especially if the kids is asymptomatic, especially pelvic kidneys and those kinds of kids. We do come across those cases.
Oh, yeah.
They're very common.
Yeah. I think if to me, the decision about an intervention would be the nature of the stone, its location, how did they present, rather than the function. Those are kids where we would certainly have gotten a CT scan eventually, and I would infer from the parenchyma relatively function. I mean, if you've got poor-looking parenchyma, a nephrectomy may be the appropriate management if they're symptomatic, and then a functional study would make sense.
Okay. Last question.
Yeah, thank you. I came across a few cases that they will have bilateral stones, multiple small stones, and some of the stones, like 11 stones in each kidney. There are non-obstructive stones. The patient was evaluated, cannot be hypercalciuria. I'm sorry, hyperoxaluria. So how do you approve these patients? I 5 years to do for these stones, and turned out to be she expelled one stone, turned out to be calcium 100. And the stone was attacked. It was not a broken piece or something. So I did multiple ureteroscopies for that, because medical science for these kids are quite hard. So do you have any other recommendations other than doing ureteroscopies for these patients?
No, I think they're perfect for ureteroscopy because you've got small stones. You can, I mean, depending upon age, you can put up a sheath. So if you're going after multiple stones, you're going back and forth. It'd be nice if we could, I mean, some people will laser them and just dust them and then not retrieve the pieces, but I like retrieving the pieces. I think the difficulty in those is if you have got multiple small stones and you're asymptomatic, is when do you choose to intervene? And there's no clear answer for that. If the family's willing, I'm more than happy to wait on those and see if they'll pass. But you're at the same time correcting any metabolic things that you can correct.
Last question.
Good to have the last question. So using the ureteroscope in 11 months boy, the one you show us, how easy is it, and what's the appropriate sizes you use for ureteroscope in such a, because you found this one of the very difficult tasks.
Yeah. It depends upon if it's a distal stone. There are some very small needle scopes that the tip is 4.5 French, and I think it's Stort's. And for a distal stone, I think that's better than a flexible. But if it's proximal, then the smallest flexible is, I think, a 7.5 distal tip, maybe 6.5 distal, but it extends. So in those, you may need to pre-stent. Because I think that you acute stenting, it's in a small child, the semi-rigid needle scopes are nice. I used to have a very short 6.5 French ACMI scope that was great for distal stones, but they don't make it anymore.